So good afternoon. There have been, such an exciting. We have been through such an exciting day, and the last talk was just amazing. So I would just talk of the clinical side of CAR T cells, and we have just completed one infusion. So much more to learn. But I'll just share my insights with you, and I hope after listening to this, you all are able to start a CAR T cell program in your institute. So what exactly is CAR T cell therapy? It is a name given to the chimeric antigen receptor, which is genetically modified T cells that are designed to recognize antigens on the tumor, resulting in their activation and proliferation, eventually resulting in significant durable destruction of malignant cells. That's a very good definition, actually. These are actually living drugs. So they can persist, they can expand, they can evolve, and they can change also with time. The subsets can also change. And we can use drugs to modify their subsets, as Professor Purvar also described. They used a drug. So generally, these are created from the patient's own blood, but it is possible that we could create from an allogenic donor also. It's not impossible, and it's being done, and they are working. These cells are also working. So what is being done? How do we produce these cells? So the first step is isolating the T cells, the leukapheresis. That is first done from any eligible patient. And then these cells are re-engineered to express the CARs, or chimeric antigen receptor. We'll talk of the CAR also, what CAR is made of. After, they're expanded in culture, they're grown, and these cells are infused back. The time taken to do all this could be about ranging from 9 days, 10 days to about 6 weeks, depending on how rapidly they are being cultured, and all the QC checks. So then they're in after a lymphodepleting chemotherapy. Why that is given, that also we'll discuss. So this is the step of the viral DNA insertion, the viral transduction. We use lentiviruses and retroviruses to achieve this. And these modified cells, they express these CARs. Always remember the structure of the CARs, and take it home with you when we discuss that further. So these are able to attach to the tumor cells, and this is not the only attachment happening. There is another attachment which is required, which we'll also talk about, the co-stimulatory pathway. So they bind the tumor cells, and this causes apoptosis. This is how CAR T cell works. So why do we need to create such therapy? Why did we need CAR T cells? We were transplanting. We were using the GVL effect, graft versus lymphoma, graft versus leukemia effect. We were very, very happy doing it, giving a lot of GVHD to our patients, and then using so many GVHD treating therapies. So there was evidence that these lymphocytes actually work, T lymphocytes. They're very exciting cells, actually. So you see here, the more you have GVHD, the more is the graft versus leukemia effect. The survival is more, and the probability of relapse in those who have acute and chronic GVHD is lower. That's where the concept of having something to kill the cancer cells, having a cell. And what was that cell? That is a T lymphocyte. And it works in the transplant. So what should be the reason why it should not work when it's refined and it is not in this crude form? So supposedly everybody thought it should work. Efficacy of DLI also is, we know that DLIs work. And this is a CLL patient who got a DLI, CML also. The post-transplant patient relapses, DLI does work. So these are the lymphocytes actually which are working. But you see in ALL, the response to DLI, you see, is not so great. And despite all kinds of treatment, outcomes of ALL, relapsed ALL, remained poor. It was about 10% in the real world, maybe lesser than that. So we needed to harness the T cells in better ways, and we wanted to dissociate the GVHD and GVL effect. This is what actually was done by our scientists. And these are strategies to harness the anti-tumor immunity. I will not go into details of this. We have bispecifics, we have checkpoint inhibitors, and we also have bikes, NK cells, CAR NK cells, CAR immune cells, and then we have CAR T cells. So all these are the ways we can really harness and use it to advantage. So has CAR T transformed relapsed refractory DLBCL and LBCL care? Probably it has. You can see here, this is basically real world data, the Scholar 1 retrospective analysis. So, and versus the Zuma 1, which is the one of the initial lymphoma CAR T study, 508 patients. You see So with in the Zuma 1 group, there is a 7.2-fold increase odds of ORR, 11.5-fold fold increase in odds of CR, and 73% reduction in risk of death. And you see the CR rates, much more 2-year survival rate in this, this is a comparison between real versus CAR-T study, which is of a controlled environment. 2-year survival rate 50% versus 12%. So there is the difference here. So you can see from the Zuma study again, the PFS and the OS, this is Zuma 5 in the follicular lymphoma. You see the PFS near about 3.5 years for all the follicular. And the response rates are very good, ranging between 85 to 80 to 85%. And half of these, see, 48% of the partial responses, they actually get converted into complete responses in time. So that's also true. And the CRS rates are going down. We are getting better at managing them. And also, mentioned humanized cards, things are getting better. Elara, again, TISA cell, follicular lymphoma, 86% ORR. And again, the PFS, more than 3 years. It is more than any of the therapies which are used for refractory follicular lymphoma. Probably mosunetuzumab comes closer to that. It's about 2.5 years. So what is the immunological basis here? We need to really, understand the, structure of the CAR-T cells and how they're designed, so we can make better cells. And all of you can go back and make better cells then. So we need to understand what is a T cell receptor and a B cell. B cell receptor is an immunoglobulin. T cell receptor is different. It only attaches to antigens in combination with the MHC. So these are different, but B cell receptor can bind anything. So what is chimeric? Chimeric is actually a combination of these two types of receptors. That's why it's chimeric. And what components are taken from each cell? What is the, this is important to understand, because, this, leads us to the structure and then the function of CAR-T cells. The various phases, what are naive T cells, how they mature. We should be aware of this chart. So exposure to antigen takes us from pre-T cell stage to the memory T cell and the effector T cells, which is various degrees of antigenic stimulation. After antigenic stimulation, they change their form. So naive T cells can be the CD4 or CD8, but they can get activated by, most importantly, two signals. One is the TCR binding to the MHC. This is one signal, and the other is the co-stimulation. The CD28 like co-stimulatory molecule binding to ligand B7. Both these are actually required for activating the T cell. Without these two, nothing will happen. The initial T cell, the first gen ones, did not have this interaction. So they were not working. They were not persisting. They were not durable. So important point. So the types of T cells which are important for persistence and having better outcomes are actually the longer standing T cells, the memory T cells, the naive T cells, and the central memory like T cells. Those are the important cells. So these actually, make the actual difference. And the more of this we have in the CAR-T product and the expansion later, the better could be the outcomes. So the design, you see here, from the antibody, they've taken a part of the heavy and light chain. That's called the single chain fraction variable, which binds the antigen actually. This is the B cell receptor. And from the T cell, they've taken the CD3 zeta, the intramembrane domain. They've just made a gene, insert the virus and inserted that into the T lymphocyte. And that's where the CAR comes out and expresses on the T lymphocytes. The transmembrane domain can be anything. We'll come to that also, but it can be murine. And many of these initial CAR-Ts, the 5, the Yescarta, Kymriah, TISA cell, and TISA cell and Axicell, and also Tecartus, which is a modification of Yescarta only. All these are murine CAR-T cells, but in India we made humanized CAR-T cells. That's the difference, and the transmembrane part is important there actually. So this is the hinge region which I was talking of. So this is the structure. Please take the structure back home with you and always remember this, because this is how CAR-T is designed. This is the co-stimulation is a part of second gen CAR-T cells. All the commercial CAR-T cells today are second gen CAR-T cells. So this co-stimulatory domain can be mostly of two types, CD28 or CD41BB. These two differ, with some minor points clinically. There's a slide about that. So this is evolution of the first gen did not have this. The new gen has 41BB, and now we have OX40. We have two co-stimulatory domains, third gen CAR-T cells. Even better at activating, the T cells and more persistent. So this is even better, getting better. Fourth gen, dual chain CAR T cells and universal CARs, and the trucks was T cells were redirected for universal cytokine mediated cell killing, which has also a gene inserted for cytokine production, and it can actually take care of the immunosuppressive environment which is there in certain tumors, especially solid tumors. So these are getting better. There can be armored CARs also, so differently made. So all this is going on. The approved, these are not a part of the approved CAR T cells right now. So these are the various types of constructs used by institutes. These are institutional CAR T cells, MSKCC, NCI, Baylor, and UC, various places. They have slightly different, the constructs, differences in the, the hinge region and the co-stimulation which they have used, 41BB versus 28. And these are the, commercial CAR T cells, Novartis, Juno, which are tied up with institutes, and there's a various co-stimulatory domains which they have used. So the various commercial products, the hinge region which they have used, the spacer domain you see here, CD28, IgG4 hinge, all these can be used, and many of these are murine. So this is the region actually which is murine, and this is making a difference. And the co-stimulatory domain could be 41BB or 28. So the co-stimulatory domains do matter a lot. The peak of the expansion is different, and the CRS also is different. So what happens here, if you have a CD28 co-stimulation, the peak is earlier. It peaks within the first 7 days, causes a lot of CRS and goes away, doesn't persist. The 41BB, it peaks later, 2 to 3 weeks. So the response is also later, and CRS is and lesser. But they persist more, they're durable. But till now, the data has not shown that this persistence is changing the outcomes. The data is not showing that. Even when the CD28 cells are going away, they're still leading to durable responses. So what defines a good tumor antigen? So it should be on the cell surface, it should be having consistent expression on the malignant cells, should not be downregulated, should be critical to the tumor cell, and expressed on malignant stem cells, more the better, and not expressed on normal cells, so no off-target toxicity. And most of the antigens which we are using right now are lineage specific antigens. They have some little bit of off-target effect also, including CD19. So Indian initiatives we have discussed. Professor Purvar's initiative, Dr. Gaurav Narula, they have brought in the indigenous CAR T cells. There's another initiative going on at NH, and Dr. Sunil Bhatt is leading the way there. Immunil is the company which has done it. They have also recently published the Imagine study, 11 out of 20 patients. Actually, we got this slide made, and this was 77% of, but they have published more data now. So coming to more of clinical, part of treating using CAR T cells, bench to bedside. So very important part here, leukapheresis. So leukapheresis, what is the target cell dose? Till now, what exactly should be the dose? But the collection goal for transplantation we know is this, but the current protocols for the CAR T cell we target processing 12 to 15 liters, and the goal is approximately 5 into 10 to the 9 mononuclear cells. That's just a ballpark figure. Factors which affect the lymphocyte mobilization. So the absolute lymphocyte count, if it is too low, difficult to get the desired dose. The use of steroids, quality of T cells goes off. Use of bendamustine or checkpoint blockers, ibrutinib before the leukapheresis makes it difficult for manufacture. There is a 20% failure of manufacture, 10 to 20%, and there's a 20% failure of expansion in the body, in the patient's body, and especially these are the factors which are contributing. Bendamustine, use of bendamustine before the leukapheresis. So the disease burden, active disease and peripheral, this is the suitable excess for apheresis. Obviously, the patient has to have a possible way of harvesting. So these are kind of GMP labs which are utilized to manufacture CAR T cells. And this is actually a photograph from one of the labs. So which vectors are better, lentiviral versus retroviral? So this is an important point. But in terms of the efficacy is not making too much of a difference as per the data. So, but as opposed to the retroviral vectors, lentiviral viral transduction is not governed by cell division. So you could actually, transduce any cell, and non-cycling cells. The terminal differentiated cells also could be actually transduced. So, but there are many different ways to approaching, and so many centers are using so many different approaches. So what the patient journey we have seen, the apheresis, the transduction, the expansion, and the infusion. So why is lymphodepletion necessary for expansion? So what happens is, it not only potentially reduces the disease burden, but also, it eliminates the Tregs, the tumor suppressor cells, or the Tregs which are creating an immunosuppressive environment, and also provides the most important point, homeostatic cytokines, which is IL-7 and IL-15. They cause more and more expansion of the CAR T cells, and it upregulates the immunogenicity. So this is the most important reason. The homeostatic cytokines are the most important reason why lymphodepletion is actually important. So these are the regimens which are generally used: fludarabine and cyclophosphamide. They increase the CAR T cell expansion, and flu-cy is the protocol which we use. The doses in different protocols could be 25 to 30 milligram per meter square, 3 to 4 days of fludarabine, and could be cyclophosphamide 500 to 1500 milligram per meter square over 3 days. Those are usual protocols. They could be slightly different from one product to another based on the clinical trials which they have been used in. Depleting regimen, flu-cy is the most important. There was some fludarabine shortage in the US, so they have tried other drugs also. But flu-cy is the most important regimen. It's the most commonly used regimen also, and we don't have a shortage here, fludarabine. So practical considerations: the patients are, this is, could be patients could be outpatient basis. There's some studies going on in the US, but in those studies, 70% of those patients actually they were actually readmitted when they were given infusion outpatient basis. So not so easy. Patients who have very low lymphocyte counts at the outset, they might actually not require lymphodepletion because they're deplete. So the indigenous CAR T cells, how are they different? Are they, there's some differences because the toxicity is so little, there's hardly any serious CRS happening. So the most important difference is that they're humanized. So the murine element is much less. That's why they're not called, difficult CRS and ICANS. The manufacturing process is also manual with the IIT CAR T cells. And that is a major difference with the automated strategy. You can make only CAR T cells for about 2-3 patients in a month. But I hear that the ImmunoAct facility, they can make CAR T cells for about 40 or 50 patients in a month. That's a big number, and it can probably cater to the whole nation. So obviously shipping also has some problems, how to ship. They have to be SOPs. So, generally the, CAR T cells are shipped back in liquid nitrogen to us. We got liquid nitrogen. How they are, sent back? Are they sent in, normal saline? Or they sent, severely, plasma reduced, or, volume reduced in small, aliquots? That's how we got it for our patient. So all that matters. And those are the clinical issues with infusions. So what are the advantage of CAR T cells? They are a single time infusion mostly, although repeat are possible, are being looked at. And also their HLA, there is HLA independent antigen recognition. So therefore they have a universal application. The target antigens could be anything. It's not only CD19. They could be any antigen. So post CD19 CAR T cell therapy, the relapses are CD19 negative, half of the relapses. So people are using CD22 CAR T cells for that. Or they're upfront trying, CD19 and 22 dual CAR T cells to prevent those relapses. So all that is possible. And we are talking of lymphoma today. I'm not touching upon myeloma and, ALL today, but we'll have another preceptorship for ALL and, all these things. But they have a minimal risk of GVHD, and, they are very safe. And with the humanized CAR T cells, you saw the CRS is hardly there. So they're powerful, they're specific, and they have a memory, they persist, and they could be universal also. And we are on track to get allogenic CAR T cells also. Toxicities, the most important ones, they are the most important 2 toxicities, CRS and ICANS. The most important to remember how to manage it. That's how your CAR T program will be running smoothly. Till now in our patient, luckily we have only had one spike of fever, but things can go really wrong with CAR T cell therapy. So acute toxicities could be CRS, ICANS, cytopenias, persistent cytopenias, not uncommon. Acute infusion toxicities, uncommon. Tumor lysis syndrome, not common. HLH is not so common, but it is a life-threatening problem, and you need to identify and pick it early and treat. Anaphylaxis, not so common. So CRS is actually a supraphysiological response following the activation and engagement of T cells and any CAR immune cells, any immune effector cell, and it can cause so many different problems, making hypotension, hypoxia, end organ dysfunction, and symptoms, generally are linked within a few days, few hours to few days of the CAR T infusion, not defined by cytokine levels. You can have normal cytokines, but the symptomatology, that is what defines CRS. We need to, take that home. So this is the grading system. Three things: fever, hypotension, hypoxia. So you see here, so if you have only mild fever, it could most likely be grade 1. And if you have some hypotension, and you don't require vasopressors, it becomes grade 2, but you require one pressor, grade 3, more than one, grade 4. And if you have, hypoxias, various degrees, you grade it this way, and you trigger your treatment based on this grading. But also there is a clinical sense to it. If the fever is persistent and the patient is sick looking, you could trigger your treatment at that point of time. The waiting time to treatment for CRS is reducing, has been reducing. In the studies also, the trigger for giving toci, trigger for giving steroids has gone, and that's why the toxicities are now lower, the mortality is lower. So who is at a severe risk of CRS? You see, patients who have a high tumor burden, have disease progression, ECOG PS, important, and products which are associated with the rapid early expansion, like the CD28 CAR T cells. So they have a higher risk of CRS and severe CRS. So the primarily these are associated with ICANS also, but primarily CRS. So if you have pre-existing issues with the heart, high baseline CRP or IL-6, or higher doses of CAR T, although Professor Purvar mentioned that he has gone up to 15 million per kg. It's a very high dose, but in the most of the commercial products, the range is between 1 and 2 million, and some of the lymphoma studies maybe 5 million, but 15 million is a lot. But humanized CAR T cells are not causing any toxicity, so it's okay. So clinical signs and symptoms: fever, rash, nausea, vomiting can happen, and tachypnea, hypoxia, any kind of symptom, elevated D dimers, renal dysfunction, hepatitis, neurological problems can happen. These are very subtle changes, change in handwriting. So we should make it a point that we should ask the patient to write on before the day of infusion, and then follow the handwriting daily. Subtle changes in the handwriting, it could be actually a harbinger of severe ICANS. So that's a way to pick up ICANS. There are other scoring systems also. So the typical onset of problems is few hours to few days. The CRS, if it is a CD28 co-stimulation, please be aware, if you're using CD28 co-stimulatory domain, then the CRS is going to be early, within the first 7 days, could be few hours. So we have to keep ourselves alert. The CD41BB could be later, it can still happen. So we need to be alert to that possibility. The ICANS peaks around day 7, later than the CRS, and those are they present differently, but they can be coexisting. So the treatment could be actually catering both of these. It was very similar situation to what happens when we have a bad patient with GVHD. So many things are going on, endothelial dysfunction is going on. So there could be overlap between a lot of problems. So in the clinical setting, sometimes definitions may go blurry. So very important to differentiate sepsis from CRS, and there is already studies going on there, and there's some biomarkers which are being used to separate out the two. But yes, when we have a sick patient, we have to do everything, and sometimes these patients have to be started on some antimicrobials also. So how to manage the CRS? The most important drug, even in grade 1, if the fever is persisting, grade 1 toxicity persisting, please give the toci immediately. And you could give up to 2 doses, and if the 2 doses and with the second dose, if there's no improvement after the first dose, maybe 8 to 12 hours, you could also consider adding dexamethasone. The dose is generally 10 milligrams IV 6 hourly, and that's how the CRS is managed. Obviously the grade 3 and grade 4, needless to say, dexa and toci are the drugs of choice. Some centers, some institutes use anakinra also as a second line, and the ICU team has to be alerted when you have patient admitted for CAR T cell infusion. So you have to have an ICU bed available. But with the humanized CARs, all this actually, what I'm telling you, may actually change completely. It may be so cool and chilled out that we can't imagine, but it could be. I am not, going too far ahead in time right now. But what we are seeing from the humanized cards, that seems possible. So earlier steroid use, does it impact outcome? It doesn't seem so. If you're slightly, your threshold for steroid use is lower, it doesn't seem to, impact the outcome much. The CRS, the cohort 4 in Zuma 1 was the cohort where steroids were used early, but the CR rate did not change. The duration of response also did not change much. So save the patient first, and then we could think more about the persistence. The ICANS, there is a scoring system. The I score is available on I think StatPulse on .com. That's a website. You can just enter the mental status examination there. You will get the I score, and the I score decides where in the spectrum of ICANS your patient falls. Not a very difficult thing to do, but yes, handwriting, just basic circadian rhythm, subtle differences, subtle altered sleep patterns, they could also be guiding you on mild lichens. Mild lichens, nothing is to be done actually, but when it's getting severe, you have to treat it very aggressively. So grade 2, the treatment we start with dexamethasone. The dose I've told you, 10 mg 6 hourly is the general dose. If there is concomitant CRS also, please give the toci also. And obviously, if there is more grade, grade 4, you have to give a higher dose steroid, which is generally methylprednisone, 1000 milligrams pulse. But we will need a lot of education and awareness. All this is a lot of theory, but we need to do more and understand these cells more. So please start your CAR T-cell programs. We have started the transplant programs already, all your centers. I think we need not hype this too much. We need to learn it and apply it, and not overhype it also. Okay? Because we are capable of doing it in India. So all of us are. So what the ICU team needs to know is management of CAR T-cell therapy associated complications. Please have some sessions with the ICU team before you admit the patient. Aggressive fluid administration should be avoided. Tocilizumab should be administered, should be kept ready to be given whenever we are admitting a patient. And steroids, we can keep a slightly lower threshold. And the dose you have seen here, the 10 mg dexamethasone IV for severe neurological toxicity. So my take home is CAR T cells have finally arrived in India, and we should be hopeful, and we should all learn more and progress together. And feasibility and safety has been proven. There will be a learning curve, but I gather it should be okay. We should learn fast. And indigenous CAR T cells will be a lot cheaper. We need to be aware of how patients are selected, which patients are suitable. And we need to really dig into the trial data and be aware. But the trial data is not telling the real story. Many more patients who are not in the trials actually are eligible for CAR T cells, and there is real world meta-analysis data already coming out in that regard. So within those exclusion criteria also, some patients are still candidates for CAR T cells, and they will benefit. So transplant, we cannot forget it. Even when CAR T cells are there, the cures still will happen, especially in ALL. So long-term cure rate for large B-cell lymphomas and B-cell lymphomas could be about still 35-40% in the relapsed refractory setting with CAR T-cell. Response rates could be 70-80%, but we are talking of high-grade lymphoma, B-cell lymphoma, the cure rate is about 35-40%. So we need to do more. It's not a lot. With ALL, the long-term cure rates is about 60%. So still a lot of patients are going to be difficult. The responses are 90%, but the long-term cure rate is still lower. And we still need to we'll need to be transplanting our patients post achieving MRD negativity. But yes, we are improving. Better CAR T cells will also come. The bispecific antibodies are going to give us very robust, strong competition to the CAR T cells. They're doing very well. So I think, but the problem is the longer schedules of treatment. The drug prices are controlled by so many MNCs, but the CAR T cells is something which we can actually manufacture, and we could actually control the prices, and it is a single time infusion. So cellular therapy for India could be a better answer than all the MNC bispecifics. So I'm not sure of that, but I'm just making it a point for you to think about. Thank you. So any questions here?
Does administering tocilizumab, there's a theoretical risk that if you administer it for CRS, it increases your risk of ICANS. Is that just theoretical concern?
So I think there is no conclusive evidence that it does that. but I'll need to look more into it. But I have not found any conclusive evidence that it does that. Yeah.
So for large B-cell lymphomas, basically sequencing between your CAR Ts and ADCs and bispecifics. Basically, if you give CAR Ts, it causes a B-cell aplasia, then you cannot give your ADCs and your bites later on. So how do you exactly sequence it?
So it's a very difficult question. Post CAR T, what to do? Actually, I don't think there is very hard data to that. Post CAR T progression, how to manage. So unfortunately, I don't have a clear answer for your question. But probably the bites. I looked at the compassionate access.
They have to be ideally used before.
Ideally used before, but I think it's not an exclusion for the compassionate access study. At least I can tell you, there is a patient which could actually look at bite post CAR T. So I think still they would be eligible for a bite, because CAR T post CAR T the patients are eligible for another CAR T, different type of CAR T. And if the bite which you are using is a different type of bite targeting a different antigen, I don't think it should be a problem. You could use it. For post CD19 relapse, post CD22 CAR T is a treatment.
Sir, about the leukapheresis for CAR T, you mentioned the dose of the cells were quite high. So is it very much different from what we do from in the program?
So it is not very much different. So leukapheresis dose, there's no defined dose actually truly. So it's just the constraint of how much you can harvest and how much volume you can leukapherese safely. That is generally sent.
The volume of that product is in
Generally, 12 to 15 liters of blood volume is processed, and we generally get 200 to 300 ml of the product, and that's what we send. That's what we did for our first patient. That's all the information I have for now. Yeah, please, sir. Thank you.
Actually, from the perspective of radiation, actually, I mean, somebody had asked about the indolent, why it's not responding to radiation.
Why is it responding well? That's what was
so
asked.
that's what, I mean, radiation has got immunomodulation effect. It's different how it acts in lymphoma and how it acts in other solid tumors.
Yes.
So lymphocytes are here, the lymphocytes are the target. So the activated lymphocytes are more, rather the resting lymphocytes are more responsive than the activated lymphocytes. And that is one aspect. Another aspect coming to the CAR T cells, you have the aspect of having this, it could help in the conditioning of the tumor to the later you're giving CAR T cells.
You're saying after CAR T cells or before, like a bridge?
Before to
Yes,
condition it.
there is a very
T-cell,
preliminary study to that effect.
T-cell migration would be better. And also there could be by the way of MHC pathways also, or the tumor necrosis factor ligands.
So similar to how it potentiates checkpoint blockers,
Yeah.
it theoretically should potentiate CAR T cell. And there is a phase 1 study to that effect, where the bridging radiation actually improved persistence and outcomes.
Yeah.
So, and I shared that study with Rishabh also.
Yeah.
And I'll share that with you. But there is some, data to that effect. So I think because the waiting time for CAR T cells in the US is so long, India is not going to be too different, probably.
And
Maybe
suppose
3
it
months.
is
So bridging with RT makes sense,
Yeah.
actually.
And of course in antigen naive
Yeah.
tumors, it could also help.
So
in that.
RT makes the tumor more antigenic.
Yes.
And it will switch on, the antigenicity.
Yeah.
It's immunogenic. So I think CAR T should work better theoretically
Yeah.
with any RT. And some of the other drugs, so many strategies, checkpoint blockers, venetoclax, lenalidomide. We looked at some of the preclinical data, very interesting.
Yeah.
In fact, venetoclax actually upregulates CD19 on the leukemia cells. And also, by giving venetoclax, the preclinical data shows that the PD-1 levels also increases in the blood. So there is, there is something going on. But what I know is in the CLL CAR T study, the venetoclax arm was closed prematurely by AbbVie. Why that happened, nobody knows. Something wrong must have happened. So theoretically, I actually was planning something with venetoclax, but I have let it go because of this very idea, this very fact, which I came to know. And this was told to me by Dr. Nitin Jain, actually. I spoke to him. And this is what I came to know. So with all the preclinical data, still there is a scare that venetoclax is doing something off. I don't know. Mysterious area, not disclosed. The arm was closed prematurely. Yeah, please, please.
In CAR-T flu-cy, we are using actually for lymphodepletion. But is myeloablation totally done? If so, when is the neutrophil engraftment and platelet engraftment in this CAR-T cell?
So very good question. I've never even thought of it ever, because in the context of CAR T cell therapy, I don't think if there is anything as a neutrophil or a platelet engraftment. It is totally non-myeloablative conditioning, and it is just done to create a lymphopenic environment to stimulate the release of homeostatic cytokines. That's the reason for giving it. It is not decreasing tumor burden. It is not causing any toxicity. So that it's an NMA conditioning, and this is the way it has worked in the studies. So there is no concept of neutrophil engraftment or platelet engraftment. You have some cytopenias. In our first patients, we hardly had any cytopenia. The lowest neutrophil count which he had is probably about 800 or 1000. It is an NMA conditioning.
So the rate of infection is very less compared to that of
Rate of
autologous.
infection
Sir, matlab,
is
febrile
it must be
neutropenia
low.
or
It is low. It is low only. The infectious problems with CAR-T are not many during the peri-infusion period, but later on, the rate of infections, atypical infections should actually, and they actually increase. So a lot of prophylactic strategies actually are used, which is antivirals, PCP prophylaxis, antifungals. So I read a survey and I got to know that most of the US oncologists, they use fluconazole, they use Septran, PCP, and they use acyclovir, all of them. And then after 3 months, they also use, COVID vaccination, and then they start vaccination as the immune reconstitution happens. This is the real world policies. But infections do increase after CAR T cell infusion. They cause B cell plasia. Many of these may require long-term IVIG replacement also. One patient I saw who was treated in MD Anderson, Dr. Swami treated him actually. It was a follicular lymphoma, 3B. So for follicular 3B, we should be aware that Lisocell is the approved cell. And Axi and TISA are not approved for 3B. They're approved for 1 to 3. So he got Lisocell. That's probably Breyanzi. That's the cell, the trade name. So I'm not talking of ID and Cilta-cel today here. We'll have another session for myeloma, but this is only about lymphoma I'm saying. So follicular 3B responds well to Lisocell, and this patient had a CR. He actually went to MD Anderson in disease progression. He called me up from Dubai. He used to stay in Dubai. He called me up that I'm having progression, something's happening. He came to India also. Then I spoke to him. He got some pre-phase somewhere. And then, we discussed that CAR-T could be a possible option. And he was looking for clinical trial. He got a slot in MD Anderson. But at 6 months, he has some renal dysfunction. He has developed retroperitoneal fibrosis. I discussed with the MD Anderson team also. It's not a usual problem, but I've seen this happening in this patient. Maybe because the nodal burden was in the abdomen, that is the response has caused the fibrosis. We don't know.
Thank you,
Thank you.
Prashant. Thank you.